Hello and welcome to Conversations with Dr. Bachner. For those who've been waiting for the live stream, I apologize. We had a technical glitch. I am delighted today to be joined by Katherine Auger, who has authored a paper that we published 3 hours ago. The paper is entitled Association Between Statewide School Closure and COVID-19 Incidence and Mortality in the U.S. Welcome, Katherine.
Thank you.
And our editorialist, who wrote an editorial for the paper, Julie Donohue. Julie is a professor, vice chair of research, and co-director of the PhD program in health policy at the University of Pittsburgh. Welcome, Julie.
Thanks, Howard.
So 2 months ago, we published what was then the first opinion piece about schools opening in the fall. It was by Jeff Sharfstein and Christopher Morphew, and it was entitled The Urgency and Challenge of Opening K-12 Schools in the Fall of 2020. This issue has consumed an enormous amount of attention, press. It's in the newspaper virtually every day. The CDC, the American Academy of Pediatrics, now the National Academy of Medicine have all released reports about how schools should open. And on our doorstep arrived this remarkable submission. Probably 6 weeks in getting it from submission to publication. Took a lot of work because it's a very complicated analysis. So again, I want to read the title, Katherine, and then I want you to talk about it. And then, Julie, I'm going to ask you to reflect on it. You had reviewed the paper for prior to publication, and then you are the editorialist along with Elizabeth Miller. So the title of the paper is Association Between Statewide School Closure and COVID-19 Incidence and Mortality in the U.S. It has enormous implications for the fall. So, Katherine, take it away.
Thank you. So I'd like to tell you a little bit about what we did. So we looked at the incidence and mortality of COVID-19 at each state at the time that schools were closing. And we did a time series analysis to follow those trends over time. And then we allowed for time for the policy to take effect. So for incidence, we allowed for 16 days for the time that schools would close to when we might see a difference in the number of cases. And for mortality, we looked at a time lag of 26 days from when the time schools would close, and we might see a difference with deaths from COVID. And using that time series analysis, we did two different things. The first thing we did is we followed the trajectory of the cases and of the deaths until the end of the time lag. And we recognized that while all schools did close, it would be important to understand what might happen if schools hadn't closed. So we looked at the end of that lag period and we projected a linear projection of what would happen if what might have happened if schools hadn't closed. And that allowed us to get an estimate of schools, what could have happened with incidence and mortalities without schools being closed. And then we compared it to the modeled estimates of what happened with schools closed. So that was our first comparison. Our second comparison was really about when schools closed. So some states closed very early in the pandemic before they even had any cases or very few cases. And other states closed schools later once the cases in their state had already started to increase. So we examined the lowest quartile when the lowest quartile of states when there were the fewest cases and compared it to the highest quartile of states when there were the most cases when schools closed. And with those comparisons, we could see what the difference is in closure between states that closed early compared with states that closed later.
The findings.
Sure.
But so let me first interrupt. I want people to understand, because we don't have time to go through the details. You controlled for many, many other variables. It's really important to know that. The age of the population, the rate of obesity, social deprivation index, and other types of public health interventions that were occurring. You don't have to list all of them, but there were many, many other variables that were controlled for. Go ahead, Katherine, the results.
Absolutely. The results. So when we did our projection of what would have happened if schools remained open compared to when schools were closed, we saw a difference of 423.9 cases per 100,000 over that 26-day period after the effect of school closure. In terms of death, comparing the projections from being open with closed, we saw 12.6 fewer cases per 100,000 over a 16-day period associated with school closure. And then when we compared those early states with the later states, we observed that the states who closed their schools later, so remember that's when they already had many cases of COVID in the community, we saw 128.7 cases per 100,000 more in those states compared with the lowest quartile over that 26-day period, and 1.5 more deaths over that 16-day period from the highest quartile to the lowest quartile.
Julie, how do you wrap your heads around the study? You saw it when it first came in, and you knew that it went through substantial revisions around the models that were used, the statistical and methodologic approach. And then it took us a long while to sort out ways to try to get to absolute differences. How do you think of this study from your standpoint?
So first of all, I want to commend Dr. Auger and her colleagues for taking on this crucially important question and for treating the analyses so carefully and for their cautious interpretation of the results. So what this study is trying to do is take advantage of the natural experiment of all of these school closures, and I think we'll all remember that period in March. What you'd like to have in a study like this is a true counterfactual of a state that never closed schools, but maybe adopted other interventions. And as Dr. Auger mentioned, all 50 states closed schools. It was really unprecedented. So what we're left with in terms of variation is the timing of school closure relative to where the state was in the epidemic. And one of the real challenges in teasing apart the effect of school closures from non-essential business closures and stay-at-home orders and some of the other really drastic and blunt instruments that states adopted is that they were adopted in such close proximity to the school closures, in some cases 2 or 4 or 6 days later. And so you have to make certain assumptions about the lag between implementation of one of these non-pharmaceutical interventions and when you would expect to see a change in the outcomes of interest. And that's just inherently challenging when you have a circumstance in which many of these things are being rolled out almost simultaneously. And I think that the authors did as best they could to tease those apart, but we still have some questions about how these different tools interact.
In total, when you look at the totality of the analytic approach and the controlling for different variables and knowing there isn't a counterfactual, there isn't a place where they didn't close schools, at least not in the U.S. And there are some international comparisons that have been striking. Do you think they got to truth, Julie?
Wow, that's a big question. So I think they got to an association that needs to be better understood. I don't know that I would characterize the estimates as effects. And again, there's so much variability in the incidence across these states and the proximity with which these interventions are implemented is quite close. And I think this is the most solid evidence we have to date of what happened in March and what impact it has. But I do think we need to be sanguine about what we conclude from the study in terms of how we plan ahead for the fall.
Now, Katherine, you've lived this study for now 3 months, more than any of us. You know the data better than anyone. Why do you think comparing the states that closed early when they were kind of on the upswing versus those that were already at the top and then they closed their schools, what made you do that, and what do you think is actually happening biologically? Did you think through that? I mean, you have a number of co-authors. So why did you think about doing that? And then what do you think is happening biologically?
Well, I think honestly, the reason that we got interested in this question altogether was we live in a state where the schools were closed very early in the pandemic. And, you know, I had other parents asking me, do you think this is the right thing to do? And I thought, how could anyone possibly know? But we should look into this. And I'm really glad we did think about timing and what the numbers are in the community with COVID and in respects to what could happen with school closure, because I think it goes to the same arguments going forward about schools reopening and thinking about the numbers of cases that there are in a community and taking that into account when you're making a decision about school reopening.
The other thing that I would add about the study and this problem in general is that school closures affect not just the behavior and the transmission among children, but the behavior and transmission among adults, both adults working in the school, but crucially parents and caregivers who now have to stay home and look after their second grader. And that's impossible to tease apart with data like these. But in future situations when we might have school closures with a different set of interventions that affect adults primarily, we might be able to understand that better.
So now I want to use that data to discuss the great debate in American society. And Julie knows, I think it's probably the single greatest educational challenge that we've faced in decades in the United States. Julie, I'll start with you. I mean, you talk about 57 million children, 20 million in college, 77 million people. So let's take college out of it for the time being. We know the newer data still suggests that very young children under 6, 7, 8, 9, 10 really don't get much disease. They don't communicate much disease. It changes around puberty. It's different for teenagers. Julie, how do you think about this question that is being debated on a daily basis with very strong opinions?
It is an incredible challenge. I think it's one of the greatest educational challenges, one of the greatest economic challenges, one of the greatest public health challenges, and it's a social challenge. And it has profound repercussions for inequality in the United States, both along health and educational lines. So, and it's emotionally charged. Because you're talking about the health and safety of children and of teachers. So I think there have been a couple of really helpful sets of recommendations that have come out from the American Academy of Pediatrics and also from the National Academy of Science, Engineering, and Medicine, which released a report just about a week and a half ago. And both of those reports really recommend prioritizing younger children. First of all, they say we should prioritize in-person learning full-time to the extent possible, given what's going on in the community. But we should really prioritize certain groups of children for in-person learning. Young children, children with special needs and disabilities, and also recognize that not all students have equal access to online learning, because they lack high-speed internet at home, they lack devices that allow them to engage with their teachers remotely, and that we really need to keep those groups in mind in particular.
Katherine, how do you think about it?
Yeah, I agree. I think that reopening really is a conversation about three things. One is what's happening in the community. What are the numbers in the cases that are happening in your community? Number two is what's happening in the school. So is your school set up to try to maximize distance between children? Do we have policies and ways to help children with face covering and increased hand washing. And the third is exactly what Dr. Donohue was just talking about in terms of prioritizing some children who need to be at schools for the special education services or for the nutrition services, and making sure that we have some children as higher priorities, and then also recognizing that some families will have high-risk individuals in their household, and that there will be families who are uncomfortable sending their children back to school with high-risk individuals in their families. So therefore, we need to be flexible and nimble and provide educational support for children in the classroom when we can, but also supporting children who are remote learning.
So I want to be clear that I think generally the broad consensus is there's not going to be one answer for every state or every school district. That's very clear, and people are already declaring some schools are actually opening for physical in-place school in a few weeks, whereas other school districts have already said it will be distant learning or learning by the internet. So let's agree to that. This is a superintendent's greatest challenge. It really is. So there's a lot of advice from different people. We have a summary of the NAM report. I've read the Academy of Pediatrics report. It's great for all of us to give advice, but you're a superintendent. You have to take care of 10,000, 50,000, 500,000 students. But they have to make some decisions now. Otherwise, if they keep delaying, I think they won't be able to get there. Either of you, are there logistic decisions that you think they can make now that may be helpful, that can at least begin to put boundaries around future decisions? Julie, I'll start with you.
Right. So I think, one decision is around what kind of face covering. So should it be a face shield or a surgical mask or an N95 mask? And the recommendations seem to be that surgical masks make sense. In terms of other logistical decisions that need to be made, there are thousands of them.
Right.
I think one is thinking about how to have smaller class sizes and how to, again, prioritize younger children who lose the most developmentally and educationally from gaps in learning. Prioritize younger students for coming back to school, and maybe take advantage of older children learning from home to free up space, physical plant in schools, and maybe see how that goes for a couple of weeks or a few months. Closely watch the data in partnership with your county health department, and then think about welcoming older children back. And some school districts are experimenting, for starters, with 2 days a week in person and 3 days a week at home. And these are all decisions that we are putting in the hands of school superintendents who, in addition to being educators, now have to be infectious disease experts and public health mitigation experts. And the other crucial component here is communication. Regular ongoing communication with a whole range of stakeholders who will feel passionately one way or the other about the decisions that are being made. And of course, all of that is complicated in an environment when we can't have a town hall. We can't have a big community meeting and invite people to deliberate on these very important decisions we need to make.
Katherine, what's the first 1, 2, 3 decisions that superintendents kind of need to grapple with and put to rest? Because if they don't put some to rest, they can never move to decision 4, 5, 6, 7, 8, 9, 10.
I agree. I think it's about the physical distancing. How can you maximize the physical distancing? And that will mean shifting of children and potentially limiting to the younger children, and also about the face masks and what facial covering children are going to be able to use. And I think it's exactly correct. We have to be able to make these decisions, but then be open to following what the numbers are in the community and adapting our decisions the decisions that they're making to what is working and what is feasible, because children are incredibly resilient and they will adapt to these norms, but we have to, and they will emulate norms, but as physicians and as educators, they have to be willing to emulate these behaviors and help children find their normalcy within these new behaviors.
The most difficult, or one of the most difficult questions, I was talking to Mike Osterholm, who's a public health expert, been around for many decades, and he said when it comes to children, it's not the denominator that counts, it's the numerator. And what he meant by that is one death. And that just creates havoc in the school system. And I think it's very clear we can't guarantee health. Now, there's other reasons why children may die early in life, same with teachers, but we know there's increased risk if we do this. On the other hand, the risk of staying home is almost unmeasurable. So how do you think about that, less around children, but vis-a-vis teachers? And you can already read about some groups, some teachers saying, you're putting me at risk. It's not what I bargained for. How do you think about it vis-a-vis teachers? Katherine, I'll let you go first on this one.
Yeah, I think we need to have policies that are protecting the teachers as much as possible, right? So that way we are able to create physical barriers, perhaps like plexiglass, so a teacher can stand and still see their students and be able to teach through them, support them with other physical distancing type of elements, help them with their facial coverings, etc. But we have to create systems that support teachers because they are essential. And we do have to acknowledge and recognize the risk that they are taking being in the classroom, just like there are many members of societies that are taking risk to help our society function in this pandemic. The teachers need to have that support. All school administrators, whether it's counselors, teachers, social workers, they all need to be supported by the school system and by our society.
Julie, how do you think about the risk vis-a-vis teachers?
Yeah, I completely agree. There will be some communities and some school districts where a large number of teachers are in that high risk group by virtue of their age or comorbidity. And I think we need to pay careful attention to all teachers, but particularly teachers who are at high risk of having severe disease. This is such a contentious issue. We may think of the best public health mitigation strategies that rely on reducing child to teacher ratios, but if we don't have enough staff coming to school because of fear, and concern about safety, our plans kind of go out the window. So this is really important.
There's a couple questions have come in. Lessons from outside the U.S. I mean, there's been some interesting studies outside the U.S. I've already mentioned one. There was a study from somewhere in Europe where there were like 3,600 people. They let 1,800 people come back to the gym, and 1,800 people didn't come back to the gym. And then a month later, they had the same rate of disease, and they said, well, you can come back to the gym, just you have to do these things. So there are these natural experiments. When I actually had interviewed Paul Starr earlier, he said one of the great losses were that we weren't conducting some quasi-experimental studies. Julie or Katherine, are you? I know of some data from outside the U.S., but I'm curious what the two of you've read. I'll start with you, Julie, this time.
Yeah, so there have been some success stories and some failures with school openings in the COVID-19 era. I think there's been some success in Norway and Denmark. Both countries reopened schools when the community prevalence was low, and both countries enacted social distancing measures in their school settings, and they have not seen major outbreaks. I think it was a different experience in Israel, but I think we're just beginning to learn about these experiences because these are school reopenings that might have happened in late spring, early summer. So I suspect over the course of the fall, more evidence will come in to shed light on this question.
Katherine, what do the results of the study that you've actually done, it was earlier in the pandemic, how did they inform how we should think about opening in the fall and then monitoring? I'm really curious about how you layered those results onto the great challenge of opening in the fall.
Yeah, to me, we bring one more piece of information, one more piece of the puzzle to the table with our study. And it really is in thinking about the numbers of COVID cases there are in a community and what that might do in terms of risk of having schools open versus closed. And, to the point about what's happening in other countries, I think that there are lessons we should be thinking about, and we should be looking at how did they do that and were they successful and how were they successful. But I think there are some limitations to the applicability of what happens in the United States when you have some countries who have the number of new cases in the entire country is smaller than the number of new cases in a county in the United States. So that sort of incidence when you're opening schools, I think is important, and I think our manuscript brings another piece of that information to the table for policymakers.
When I interviewed Robert Redfield from the CDC, and a lot of his comments were picked up, but when he said the country needs to mask for 6 weeks, my notion of what he was thinking, and I didn't ask him, was we have to get the amount of disease in the country down so we can think about schools and businesses, plus the great concern about the flu. So I was thinking he was saying, look, we have 6 weeks. People are home, they're outside. If we're going to get the rate of disease down, it's going to happen now, and we don't want to be facing this. So that's what I imagined he was thinking about when he said we need to mask for 6 weeks. It always helps to make it a bit personal. Julie, what's Pittsburgh doing?
So Pittsburgh is giving families of choice, Pittsburgh Public Schools I'm talking about here, is giving families a choice of whether they want to learn exclusively online, students learning online at home, or a hybrid approach, where there will be some days of in-person instruction and some days at home. That's where Pittsburgh Public Schools is starting. And I think they're working closely with local public health officials to monitor the situation as we reopen schools, and they'll have to pivot and evaluate their strategy going forward into the fall.
Julie, is this regardless of age of the child? This flexible approach, so that they haven't said, look, we're really going to prioritize in-school learning for K through 5th or 6th grade and allow junior high and high schoolers learn from home. They haven't made that priority.
So not as of yet, although I would say that the fully detailed plan has yet to be released. So that may be forthcoming.
Katherine, Cincinnati?
So Cincinnati is a wonderful city of many, many neighborhoods who have different school districts and different school rules. So I can tell you that there is sort of the whole broad gamma of what people are doing, but in general, it is some sort of partial, a few days in person, and the rest is online, with the option for families to be able to learn remotely completely. And that is an option that many school districts are offering. And in many school districts, they've sort of built in this, we have a color-coded system in our state based on the number of cases and other COVID indicators, and such that if we got to a higher state, all schools would shut back down to only remote learning. And I will comment that the leaders at Cincinnati Children's have been working with the different school districts in trying to develop sort of this quasi-experimental design and natural experiment, so that we can help learn what is the right thing, what works for our community, and then spread that as well.
Julie, is it your sense we can get there, or is it just going to be chaos in the fall?
I think at this point, I'm feeling like it's going to be mostly chaos. given where we are with the prevalence in so many states. If ever there was a motivating factor to help us kind of get serious and get our act together about containing the virus, it would be prioritizing educating our children. So I'm hoping we can start to see things turn around. But the reality is we have something like 13,000 school districts in this country. Wow. There are going to be 13,000 variations on a plan. And I think it's fantastic that Cincinnati Children's is helping to put a plan in place to try to learn from all the experimentation. I think we need lots and lots of studies and ideally some federal investment in learning from that variation. But I have to say I'm pretty nervous about what the fall looks like at this point.
Katherine?
I agree. I will comment that I would say that we have a lot of opportunities to learn, and we need to be ready as pediatricians, as researchers, as educational professionals to try and optimize, because this is the world we're living in now, and this is what we need to go forward with, and we need to be successful for our children.
So 2 months ago, as I've already mentioned, JAMA published the first of its pieces about school openings, the urgency and challenge of opening K through 12 schools in the fall of 2020 by Josh Sharfstein and Christopher Morphew. And then a few hours ago, we posted 3 papers, the first by Katherine and her colleagues, entitled Association Between Statewide School Closure and COVID-19 Incidence and Mortality in the United States. A second piece by Ken Dibner and Heidi Schwangaru and Dimitri Christakis, which is a synopsis of the NAM report. The big reports now are American Academy of Pediatrics, CDC, and the National Academy of Medicine, entitled Reopening K through 12 Schools During the COVID-19 Pandemic. And a remarkably thoughtful and balanced editorial by Julie Donohue, my guest, and Elizabeth Miller, who really try to balance the pain of opening and the pain of keeping schools not open for in-person learning, recognizing it's probably the single greatest educational challenge since the end of the Second World War. Julie Donohue is from University of Pittsburgh, where she's a professor of health policy. Katherine Auger is from the University of Cincinnati Children's Hospital, where she's an associate professor. Julie, Katherine, thank you both very much. And Katherine, thank you for sending us the paper. And Julie, thank you for the wonderful editorial.
Thank you very much.
This is Howard Bachner, editor-in-chief of JAMA. It's been Conversations with Dr. Bachner.